as measured by MRI, things like that, from a scientific point of view, something that would actually show that it is a targeted design. But if it does, the more important thing is that if it does delay need for more aggressive measures, then it should be that is something that should be the primary outcome, is whether or not it delays the progression of symptoms in the disease.
Mm-hmm, mm-hmm. And for you, if we think about clinically meaningful data, so they will show changes from the baseline at week 30 weeks trial, right? And New York Heart Association.
Right. That's
so I'm just wondering what's clinically meaningful for you. What change from the baseline would be clinically meaningful? You would say, that's interesting.
Yeah, so one of the things they look at is New York Heart Association class, and I think that and as a general rule of thumb, and that is meaningful because if you have shortness of breath at minimal exertion, and now you can go ahead and walk upstairs so let's say you were New York Heart Association class 3 and you move to class 1 or 2 or even class 4 and you move to class 2. Those are significant changes in someone's quality of life and probably the several years that they have to wait prior to having a more aggressive invasive procedure. But they're also quantifying it more objectively with VO2 levels, and that's really what is going to be because it's still the New York Heart Association class is still somewhat subjective, but if you have VO2 levels that are significantly changed, then that's when you show that you have an effective treatment that improves their efficiency of extracting oxygen.
And forgive my ignorance, and what VO2 levels that are significantly changed, what will be meaningful for you?
Yeah, it's hard to say because I guess the lower the VO2 level, the less, like if you have, I guess I would share, maybe I could just try to make it simple. If you have a VO2 level, let's say in the range of 10 to 15, you're probably you're probably close correlating to New York Heart Association class, 2, maybe even in some circumstances 1, right? If you have a VO2 level of 15 to 20, you're probably New York Heart Association class 2, borderline 3, 20 to 25. If you have 10 to 20, you're probably, if you're 10 to 15, you're New York Heart Association class 3, borderline 4, rather. If you're 15, 20, you're New York Heart Association class 2, borderline 3. And if you're 20 to 25, you're New York Heart Association class 1, maybe bordering class 2. So, so a meaningful difference would be, if you could shift into a different class. So that would probably be about 5, 10 points. But that's particularly meaningful for those patients that are 10 to 15. That are now shifting away, because those patients are awaiting procedures. Those patients are awaiting, they are on heart transplant lists. They're awaiting myomectomies. They're awaiting septal ablations. But either way, a change of 5 that's consistent, 5 or more that's consistent, is something that I think would be very clinically meaningful.
And I'm just wondering, the drug gets,
The drug
I
what?
wonder, gets approved. Theoretically, let's assume the drug gets approved. I wonder what, for you, what is the good profile of the drug so you could use it in XYZ HCM patients. So I'm just wondering if you could give me a perspective. So just say if the drug does this and that, in theory, I'd be using it in that and that patient, my patient.
Yeah. So for me, I mean, if the drug, it really does have to come down to symptoms because, we have measurable gradients, LVOT gradients. We have measurable VO2 capacity. Sure. But and those generally will correspond to symptoms. I mean, as it is. I mean, it just corresponds to symptoms. And I think that's why neurocardization classes is really why they have that as a major outcome. Is because what it comes down to is it going to change their ability to live? I mean, that's what a neurocardization class is. I mean, can they function at a certain level in life? And if not, then they'll need escalation of treatment. So for me, it's going to come down to their symptoms, and symptoms essentially correspond to the neurocardization class.
Understood. And if we talk about epidemiology, how many HCM patients there are roughly in the United States, and what percentage of them are symptomatic, obstructive, and non-obstructive? If you could roughly give me some color.
Yeah, no, I think that that there's been a lot of question about the actual epidemiology of these patients, particularly because they say that there's about a 1 in 500, if I recall, incidence of patients that are diagnosed with hokum. But then they also say that there's a lot of people that never are detected to have hokum and have sudden cardiac death, and so that the incidence is now becoming closer to 1 in 300. Of course, if they do mass screening, for instance, and then as far as how many of those are obstructive, I would say probably at least if they're picked up by screening, I would say it's probably closer to 15%. If they're picked up by
50.
symptoms, then what did you say?
50? Oh, okay.
Yeah,
15.
If they're picked up by symptoms, it's probably, I guess in total, I would say 20% of them probably have obstructive cardiomyopathy. But if they're picked up by symptoms, it's a much higher percentage.
And could you? Sorry, I didn't understand that. So that difference between by symptoms and it's at screening, could you explain it to me? Why there's such a big difference in terms of, if you said if they're picked up by symptoms, there will be much bigger number as opposed to screening. Right.
So I mean, if for example, okay, so I guess I'll just give you a very practical example. So let's say you have a patient. Someone's mother is diagnosed with hypertrophic cardiomyopathy. One of the things that you do as part of a screening for it is you have to screen the family, and either you do that with identifying a causative mutation and screen the family that way if you actually find the causative mutation. Does that make sense? Or you screen the family members every 5 years. And if you just, for the development of hypertrophic cardiomyopathy, and if you're just doing it for screening, you're going to find much less obstructive disease than if you were doing it for someone who's coming into you who's short of breath, and then you find out they have hypertrophic cardiomyopathy. Then you're much more likely to see someone who's obstructive. If that makes sense.
Right. Understood. Thank you so much. all clear. Thank you. And